Okay, today we're going to talk about eczema and related conditions. So, eczema is, and I want to give credit to Dr. Patty Tager, who put this lecture together for us. Thank you, Dr. Tager. Okay, so the first thing we always have to know is that sometimes appearances are deceiving, and because of that, everything that might appear to be eczema may not be eczema. So you have to make sure that you're not dealing with either tinea caused by fungus, erythrasma that's caused by a bacteria, Malcilsia fulvor, and then of course perioral dermatitis, which in my opinion is really a form of eczema. However, as we see, because the treatment appeared to be Dinosin and Metrogel, it probably looks more like a form of folliculitis or what we usually call perioral dermatitis. Okay, an id reaction is usually something that also presents with papules or tiny little vesicles, most commonly on the hands, appearing like dyshydrotic eczema, but it could also involve the entire body. Miyakis is a form of a erythematous, boggy, patchy plaque that is secondary to a fungus that goes deep into the dermis and follows the hair follicles, and that it's a reactionary process by the body that's attacking the fungus. And the only way you can really find this is by doing a scrape and looking for fungal elements under a microscope, and or doing a biopsy if you're suspicious of that, even if your KOH is negative. And then there's a condition called perianal strep, which is probably in the differential diagnosis. Now, there's a few types of eczema. Okay, I tend to call eczema anything which is inflammatory in nature, causes either erythema, papules, or vesicles. So in addition to that, what I'd like to do is I would like to add other features to that, okay? And some of the things that I'm going to include in that includes one, okay, dyshydrotic eczema for sure, and what's also known as Pomfilix in the older books, Pomfilix. We talked about the id reaction, which is a form of eczema. The id really stands for dyshydrotic. Id stands for dyshydrotic eczema, which is really related in many cases, but not all the times, to the small vesicles on the hands and feet, which are very, very itchy, and sometimes caused by a fungus infection anywhere in the body, but the feet is probably one of the most common. So just keep that in mind. Now, anything that looks like eczema could be imitated by something that is known as mycosis fungoides, also known as chronic T-cell lymphoma, CT. Okay, T-cell, we'll call it T-cell lymphoma. So therefore, if you're treating someone that you think has eczema, but the eczema does not actually get better, then you're probably dealing with other situations. So you really need to do a biopsy. If you treat someone 2 or 3 times, they're not improving. Okay, even after the first or second time, you may not want to tell the patient that you may have to take a little piece of skin. It's always better using the term a little piece of skin than to say biopsy, because biopsy appears to be a lot more dramatic, and when you're dramatic, you tend to scare people. Now, there are a lot of other differentials, like for instance, psoriasis, which we'll talk about, which usually does not itch. Eczema, it tends to itch. Okay, so there are other differentials. And then a form of eczema is known as atopic dermatitis. So what I'm doing is I'm kind of taking the category of eczema, okay, and I'm putting together subcategories, which when you look at patients, you might want to think about, and always doubt yourself, okay? The time when you don't doubt yourself is when you get either a biopsy, or if you're treating a patient and they get better, like right away. So, you know what? I'm going to just put that in there because I think we should, as physicians and medical providers, is always have doubt. Always doubt yourself and ask yourself if you really are on the right diagnosis. Okay, a rule of thumb that I have is that if you're dealing with a chronic disease, okay, if you're dealing with a chronic disease, such as, okay, and I'm going to write that down, if you are dealing with a chronic condition, always do a biopsy because you just may be wrong. Let me tell you, if there's nothing you learn today, remember this. This is so important. Even last week, one of our providers was treating a patient that she thought had lichen planus. When I saw that, I asked her if she did a biopsy. She just said no. When we did our biopsy, we found out that the patient had hypertrophic discoid lupus with a positive ANA. Had I not caught that, this patient would have lost her kidneys, etc., etc. Okay? So this is a slide that says, always doubt yourself. I still do that, and I think I'm pretty good, you know? So if I could do that, you all can do that too, okay? So remember, eczema, okay, could look like sarcoid, secondary Lewis, allergic drug reaction, etc. Okay, so there is a differential. Okay, and that is exactly why you need to think about doubting yourself. Some of us do the biopsy in the get-go, so we know what the hell we're treating. Most of us do it after, if the patient is not getting better, or if they get better and the condition continues to recur, even after we've modified, and this is a very big thing, modified the patient's behavior, okay? Behavior. And what kind of behavior am I talking about? The use of bathing or wetness, which makes eczema very bad. The use of diaper changes, which in addition should be part of the diagnosis, for instance, okay? I'm going to insert another slide in this lecture because intertrigo, okay, with, okay, seborrheic dermatitis and perioral erythema with scaling, which can imitate eczema in the very young child. The very young child could be nothing more than histiocytosis X. And we have seen that, and this requires immediate attention and probably by an oncologist at a tertiary center. So as you could see, the term eczema, which is a nonspecific term, could be a harbinger of a lot of different things. So keep that in mind. Okay. Most of us use topical cortisones to treat patients with eczema. So you have to really know how to use it. Otherwise, the major side effects of this are the following, okay? Being atrophy, stria, telangiectasias, acneiform rupture. When you put steroids on, they could give you a form of acne, acne vulgaris, acne rosacea. It could cause, you could even become allergic to some of the products in the steroid, topical steroids. And then when skin thins, you could get easy tearing of the skin and sometimes purpura. And the hypopigmentation is caused by paralysis of the melanocytes. Melanocytes in the skin. And that's what you have to tell patients. The darker they are, the more hyperpigmentation they have. But a few months later, okay, the skin color will be restored, and that's important, okay, to know. Okay. So I want to highlight, and you need to know this cold, and not only that, in patients that you might think would have a problem in compliance, okay, and overusing the medications, you need to let them know that perhaps they need to sign a consent form that will cover yourself, tell them that they've signed the form because you explained to them that all sorts of side effects can occur unless they follow your instructions to the T. And I have many times patients sign this, especially when I treat their babies, because as you'll see in a second, why I do that, okay? Now, Activate, which I really don't choose, we try to avoid using any trade names. And the reason is because if they're not accepted by the insurance, the patient will call you back and try to get you to pre-authorize the prescriptions. Now, if you want to take your time and call the insurance companies and deal with it, by all means, you can write for whatever you want to. But as a practice, we will not be doing that for anybody. We like to use medications, mostly generic. They'll save people a lot of money and a lot of hassles, okay, which do very well, okay? But if you insist of using something of a trade, by all means. I'm not telling you not to do it, but I could tell you this. We will not take the time out of our practice or workday to pre-authorize your prescriptions. So keep that in mind. Okay, now why do we talk about topical steroids? Because Dr. Tager was nice enough to let us know that there are certain medications that have been approved for pediatric use by the FDA. So, for instance, for atopic dermatitis, which is what AD stands for, you could use clobetasol, if the patient is over 12, and so on. So you could use fluocinolone over 12. You know what? if you follow this diagram, I could tell you that is why I have patients sign consent forms, because it's not FDA approved for pediatric use. But I can tell you that 99% of the time, I will use 1 or 2 or 3 of these medications. So keep that in mind. It doesn't hurt to get a signature and to spend a little time with the patient. Say, listen, you need to do exactly what I tell you. If I tell you to use the medication for 7 days, use it for 7 days. If I tell you to use it for 14, that's okay. Okay? And so usually when I write a prescription, let me show you what I do. I think you'll like this, and I really appreciate our staff who follow these recommendations. So let's assume I'm going to give a patient 2 types of medications. Let's call it fluocinolone ointment. Usually the ones I use is 0.05%. Okay. I will say on a SIG, okay, use for the, now I'm going to highlight it first, 10 days, then DC. This pretty much covers me, because if the patient uses it for a longer time and they get into trouble, at least that states that to the pharmacist, and he's going to put it on. But now I said to the patient, if you get much better within 10 days, stop using the medication and start using something of a lower strength, such as triamcinolone. Triamcinolone 0.01%, okay, ointment. And then I'll SIG it as I use for second 10 days. Okay, then DC. Okay. I promise you, if you're very specific in your instructions, and then you tell the patients, okay, there are not going to be any issues. And if you haven't signed a consent form, then you got everything covered. The patient has no doubts. She gets home, she knows, well, gee, doc, what should I have used first? This triamcinolone or the fluocinolone? This was very specific. And second of all, you limit the use of the stronger topicals. But if you don't write it this way, you're only asking for trouble. So please try to do it that way, okay? Okay, great, thanks. Okay, we're going to save everything because this is going to be on our website for our practice to see only. We will be putting some password, so hopefully you're looking at it right now. Okay, my advice on prednisone, okay, is really, I'm going to put it below here. Now let's put it on the top. Okay, and I'm going to say it twice, never, if possible, use it for eczema or related conditions, okay, including not for psoriasis. And the question is why? Bingo, because if you use it, don't come crying to me, you're going to get a severe rebound effect. The patient is going to want you to continue doing it, wants you to continue this because this is what she got better on. And if you do that, you're heading for a long problem, okay? Okay, the problem is you better start telling she's going to get premature cataracts. She's going to get a septic necrosis of the femur head. She's going to get a shift in fat from the face, from the body to the face, from the body to the upper back, etc. she's going to gain weight, etc., etc., etc. Okay? Don't ever use that. If you have a problem, I'll be more than happy to share my thoughts with you, and we could talk about it in other lectures. Okay? It also causes suppression of the HPA axis, very important. If you suppress people, you could actually cause death if you keep on prednisone for too long without reducing in a very, very slow manner. That could take only a few weeks to occur. There's a way of dealing with prednisone not to suppress patients and to decrease the possibility of the above problems. And as you can see here, there are other risks involved. I'm going to highlight this because you really have to know. Okay? And if you have someone, okay, and the contraindications are, even if you, God forbid, want to use it, you better make sure they don't have hypertension or diabetes or PUD, whatever that stands for.
Peptic ulcer disease.
Peptic ulcer disease. Yeah, thank you, Erica. Okay. So this is other conditions which may warrant against the use of prednisone. We do use prednisone for blistering disorders. We use it for lichen planus for a short time. We'll talk about that later, and you could use these as well, these contraindications and side effects, potential side effects, to explain that to the patients. And if you're going to call and you're going to keep them on for a very long time, and if they had diabetes and if they had hypertension, you need to make sure that it's going to be monitored, okay? And you might want to get the primary involved in your treatment plan. And by the way, they may not agree to do it, so now you got a potential problem on your hand because you may not get referrals from somebody who thinks you're not practicing medicine the way they would. Okay, so these are some other side effects we're not going to get into, including that. Not for this topic. We'll talk about prednisone in another setting, okay? Now, this slide talks about a form of eczema that is known as atopic dermatitis, okay? Now, you know, the more you scratch, the worse things get. Not only are you going to deal with eczema, you're going to deal with lichen simplex chronicus. We'll talk about that later. And as you know, if you're going to use clobetasol ointment, which is what Temavate is, you know, you should get consent forms in kids. And I'll tell you what I do, but I get consent and I use it in the worst kids ever. You always have to make sure that if you see eczema, other than erythematous, scaly patches, papules, that has a yellow discharge, this is what you're going to need to do. You're going to treat the patient with systemic antibiotics, and on the top of it, you could use a combination of an antibiotic cream or ointment with a steroid. And then when you see him back in 10 days, you could just stop the combination and just tell him to use a topical steroid because you need to bring some relief. Why are they infected? Because people have been scratching it, causing excoriations and superficial ulcerations, bacteria embeds in there. And so the most important job is not only to treat the infection, but in addition, put them on something that's going to stop the itch. Antihistamines are good, but they usually knock people out, including myself. So if you think you could do it, but not sedate the patient and explain and warn them against that, that's okay. This here, all free and clear laundry detergent, it's a possibility, but it's really unlikely. The most common reactions are to these paper anti-static stuff that people throw into their dryers. So as long as they're not using them, more than likely it's okay. And then a big one that I often talk about is if someone's itching, and this goes not into the eczematous phase, it's more like usually it's between urticaria and eczema. Always make sure you're not dealing with scabies. Remember, doubt yourself and ask yourself, did you do all the differential? If you walk into a room because you're either tired or lazy or stupid that day, hit yourself over the head, put some ice cubes on your face, and ask yourself, what could I have missed? There's been a few times that I've had to treat patients with scabies and apologize, okay, for their misdiagnosis by other providers, whether it's people from our practice or from other practices. So always keep that in mind to do a scabies prep, okay? And when you do a scabies prep, well, half the time it could be negative even if they have scabies. So you need to think about clinically, are they itching on the wrist, between their fingers, under their armpits, around their umbilicus area? Because scabies does not itch unless it's Norwegian case scabies, and trust me, you're not going to miss that, because then patients will have these itching and some keratinization on the deposit of their hands. Sometimes it actually looks white, and they usually are nursing home patients or immunosuppressed patients. But if they tell you they're itching on the neck and face and scalp, they don't have scabies unless they have Norwegian scabies. So keep in mind that the clinical is very, very important in scabies, because 50% of the time you won't get it right, especially if you're not a great scraper. And two, don't use the diagnosis loosely, because then the patient goes home and scares the heck out of their families. And if they're nursing home patients, they're going to become isolated, and then the whole nursing home facility will have to be examined. So don't take the diagnosis of scabies lightly, especially for patients who are in facilities, because you are rendering a diagnosis that is above what you think. Okay? So just be careful. So this is, I'm going to put in another slide which many of you forget to take notice of, okay? Anything that looks like eczema, and now let's imagine you have the right diagnosis, is made worse by water and wetness. And I say wetness because maybe they're not using water, they're using some other means of wetting the skin. And I always tell patients, no washing body. Okay? Only use washcloth for private areas, comma, and for private areas, and put scalp in the basin if you want to clean it. Okay. This no washing. People say to me, "Are you out of your mind, doctor?" I say, "Well, you know what? You see, you came to me for advice. If you rather do what you want to do, why are you here?" I said, "Well, I'm going to smell. I'm going to be stinky." You have to remind them the stinky and smelly glands are only in the armpits and groin. Okay. If they wash themselves there and in their buttock, they're not going to smell. Sweat doesn't stink. Okay, sweat glands don't produce stinky odors. What produces are apocrine glands. They're located in the groin and in the armpits. And you've got to convince them of this. Otherwise, you got to give them strong medications. They're going to go home and do the same stuff that they do, and they'll never get over it. Okay? And besides that, I'm going to say especially so where? In kids before puberty, because they do not produce oil. And what keeps the skin from being irritated are the oils that we produce on our skin. Just take my word, this is how it works. I'm not going to go into the entire pathophysiology. So if they're not there before puberty, they absolutely cannot do this. And you got to keep them away from water and soap for months. Just limit it to what I said. Only use washcloth for the private area and put the scalp in the basin. Okay? In the summer, it's a little bit easier because if they want to go to the beach, that's okay. As long as they come out of the water and they lay on the beach for a while, the ultraviolet radiation decreases the cells in the epidermis, okay, that basically package the antigens and convey them to the inflammatory process underneath the skin. These are known as Langerhans cells, okay? So UV therapy, which is used in treatment of eczema, okay, basically paralyzes the Langerhans cells from packaging the antigens that are causing the reactive process underneath the skin by inviting white blood cells through the release of all sorts of cytokines and other caustic secretions. So especially kids and the elder patient who do not produce as much oils. So you need to know, this is so important, I can't tell you. Without knowing that, and you will not see that in books, but I've treated so many people, thousands and thousands, and please appreciate what I'm telling you. I'm here to help you and help the patient understand the process. Okay. So what is pityriasis alba? Okay, pityriasis alba is a form of eczema which, with a little bit less inflammation and practically no itching, that causes the melanocytes to become paralyzed by the amount of inflammation underneath the skin. You don't need to treat it aggressively if you use like mid-potent steroids. Okay, and then after a couple of weeks, switch to lower potency steroids. And I want to go over that. The inflammation will stop, and once the inflammation stops, then you could, if they want to increase the rate by which the pigment comes back, then they could tan their skin, but avoid tanning other areas. Now, when I say that, I would put a sunblock on the good skin so it doesn't get darker. And then the pigmentation from the hypopigmented patches will catch up to their normal skin. If they just go ahead and tan, the normal skin will be darker, the whiter skin will become darker, but relatively speaking, the normal will be much darker than the abnormal. So if you put sunscreen on the normal skin, you will avoid that problem. Try it, you'll see. It works very nice. And you need to tell the parents that it's going to take a few months to get their pigment right. Now, the differential in something like this is that there's no clearing inside. Usually, if it's tinea, K facial, there's some clearing inside, there's scaling on the outside, and if not sure, by all means, do a scrape. Don't be shy, do a scrape, because you're going to put on steroids, it's going to get worse. Okay, if you're not sure, you could tell the patient, the parents, or the patients this. I'm going to put you on a topical cortisone cream. If it gets worse, don't be afraid. It means it's going to bring out the fungus. And I want you to come back quicker than my reappointment to see you. If it gets better, then we know for sure you have eczema. And please, by the way, don't wet your skin. Okay, so remember, if you're not sure, warn the patient. Patients like being warned. I would if it was my face or my kid's face and I came to see you. So warn them. If it gets worse, then you know you got a fungus. If it gets better, you know you got eczema. And don't ever use a combination because we're dermatology people. We use pure medication, steroids or antifungals. Don't start using Lotrisone. Lotrisone, a combination of both. Leave that for the primary. Let him screw it up. Because the patients will never get cleared unless you become a puritanical person. Okay. As you can see by these pictures, where do most of these things are involved? Okay. Let's go over it. Around the scalp and ears, the mid-forehead. By the way, when you see a patient like that who's black, you better continue thinking about, put a little note for us to know, is subacute lupus erythematosus. Get an ANA to cover yourself because you need to start doubting yourself. Okay? So subacute lupus erythematosus, systemic lupus erythematosus can look like a form of seborrheic dermatitis. Okay? If they have other symptoms like some loss of hair and this and that, it helps in the diagnosis. Okay, you can even see that on this slide right here. It almost looks like discoid lupus, okay? Okay, discoid lupus. Okay, in discoid lupus, 25% of the patients, only 25%, have a positive ANA. So if you do an ANA, you can miss out. But other telltale signs include, atrophy, scarring. So if you're getting to think of treating for seborrheic dermatitis, but you really are not sure, and they come back and they're not much improved, they're worse, do a biopsy, do it in an area that is not that visible, like behind the ear, along the line where the hairs come down, okay? But we're showing you some extreme cases of seborrheic dermatitis there. So it's very important that you pay attention to details and always doubt yourself. You could be the best. If you don't doubt yourself, you will make mistakes. Okay? So This patient, you can see, has some scaling here. He's got some erythema scaling there. So behind the ears, the scalp, the head and neck, usually it's the mid-center face that you see that, or the chest, okay, sometimes the armpits, okay, the scalp, even the line, or right inside the scalp. Look, if you see scaling and erythema, flaking, you should continue thinking about this. The mid face is very common around the nasal alas, the nasolabial folds. You can see the armpits, the ears here, the crease of the nose here. When it gets really, really thick, it's sometimes hard to distinguish it from psoriasis. So we call that SIBO, S-E-B-O, psoriasis. And that's an absolute diagnosis too. SIBO, S-E-B-O. I'm going to just put it, like for instance, in this fellow's notes, just so that you kind of know the term and tell whoever you want to that you've heard it before. Okay, SIBO psoriasis. Okay. Mid-face, as in this patient, nose, nasolabial, upper lips, around the ala. And sometimes that's the only place you might see it. This is what I would call not seborrheic dermatitis, but SIBO psoriasis. You have to treat it more aggressively. I will talk about the treatment in a second. Around the ears, you can see in the ears, around anterior to the tragus here. Okay, this is the antitragus, tragus, helix. Okay, and then this is the antitragus. It splits into two cruces of the helix. I'm going to just throw in a few names so you can kind of see that. Okay, so look, topical steroids go from class 1 to class 7. Okay, depending on the age of the patient and the severity of the problem, you may use stronger or weaker solutions. You're going to see the patients back in a couple of weeks anyways, in 2 weeks. You can always adjust that, okay? When you start out, you really need to gain experience, so you have to be more conservative. And so these slides are not absolute. They vary depending on the patient's age, the severity of the conditions, etc. Okay? But I want to tell you certain things that work very well, especially in the teenager to the adult. Okay? Dermasmooth FS oil is a combination of peanut oil and clobetasol solution. You put this on the scalp when the scalp is wet, not drippy wet. You then have a patient put the shower cap on top of that and wash it off in the morning with a strong shampoo, tea gel, any one of these. Head and Shoulders are very good. I like it a lot. I also like the tea gel a lot here. Then they wash it off in the morning. And then you could use it every other night, okay? If for any reason the scale is really thick, okay, and you will know when you see them, then what you should do is add 25%. This is a teenager to adult salicylic acid in either acid menthol cream, which is sometimes not found, or hydrophilic ointment. And again, covered with a shower cap and placed on a wet scalp. Shower cap and wet scalp overnight. And what you'll find out is when you alternate that, it's really a wonderful thing. Now, let me reduce this so it all appears in one location. Because what I want you to know is that even though you're doing this treatment, which is very, very nice and very important, during the day, as the patients put on either clobetasol solution, which is class 1, or fluocinolone, 0.05% solution, which is a class 2, twice a day on the scalp. If they put the nose right to the scalp, then they won't look greasy during the day. Okay? So that's what you should do. There's some people use Loprox shampoo because there's been thoughts that maybe all this is due to fungus. I'm not a big believer, but if you want to use it and see, try it. I can't tell you that it doesn't work. Westcorn cream or ointment is something I like to use, but I never use it as a trade name. It's also known as hydrocortisone valerate. But this is a good introduction to the way you approach seborrheic dermatitis. And as the patient gets better and better, you don't just totally stop the medication. You tell them to use it less often. Okay, maybe you don't need the salicylic acid because they don't have a lot of scale. You might want to tell them to use the Dermasmooth FS oil every other day, or once a week, or twice a week. With a few days in between. And you don't tell patients to come PRN because you could decrease their coming to see you. But what I find is that when they get so lax about letting someone check their head, they usually get flare-ups, and then they need to start using stronger and stronger medications. Okay, what are we looking at here? Perifollicular papules. See, and not only that, they all look pretty homogeneous. There's some smaller, but many of them look very much alike. Same thing, you see, they kind of give the same appearance. They occur in the arms, any part of the body but the arms and the trunk. And the patients come in and they tell you, I don't like them. They don't say they itch. They say, I don't like them. Okay? And what we're talking about is keratosis pilaris. You can see it has some form of genetic predisposition, and appears mostly on the extensor arms and upper lower extremities, the cheeks. They could occur anywhere, actually. Okay, and they're form of papules, and you cannot make them go away. So don't ever tell a patient you're going to cure them. You can make them look better. So usually, and they're not related to bathing like eczema does. So you could put them on lachydrin, use it for a few weeks, then you come back twice a day. Actually, you could do it like, let's put it here as BID. You come back 2 or 3 weeks later, you still have some, so now you do retin A. And the retin A, you alternate it. So you use that QHS, and the lachydrin would be QAM. And then you just keep doing that, and it'll get better and better and better. And then if you want to make the lachydrin even harder, you could use urea products, which we could talk about in the future, and go that way. Some people like to use some anti-inflammatory products. When it's severely red, there might be some inflammation, so you might want to use it temporarily. Okay, that's why it says 2 weeks. 2 weeks is temporarily. Okay, 2 weeks is good. And then see it back, a month later, 2 months later. Okay, and kind of reevaluate the patient. So again, this is in patients with of color. This is in a Caucasian. It can occur in the forehead, any part of the body, even the face. This person has a form of rosacea without the acne, so it appears right on top of the rosacea. So it could occur in the face. That's really when it bothers the patients, and they really want to do something about it. The back, the forearms, very, very common. Okay, allergic contact usually shows some sort of demarcation. It's usually very, very itchy. There's usually a preceding history. It becomes somewhat lichenified because patients tend to scratch it. When you scratch things, they become lichenified and they become hyperpigmented all at the same time. So it's really important to avoid scratching. Okay. You'd like to get a history of what the contactant was. So history in this case is important. Sometimes it's due to things you place on it, and that's why it's called allergic contact. You've been in contact with something. A poison ivy, oak, or sumac is a form of allergic contact dermatitis. When you see it acutely, meaning when you first see it, and if it's got blistering and it's beginning to spread, or blistering and it's widespread, this is one of the conditions you put patients on prednisone and Tagamet, the Tagamet to protect the heartburn. I usually put them on prednisone with Tagamet twice a day. I usually keep them for at least 2 weeks on it at a dose of 60 milligrams for 5 days, 40 milligrams for 5 days, and 20 milligrams for 5 days with an antacid, Zantac, whatever you like to use, Zantac, Tagamet, Prilosec, whatever that may. A lot of them are already on those kind of medications. Usually they show linearity. Contact dermatitis have linearity. There are other conditions that show linearity, like verruca vulgaris has linearity, lichen planus has linearity, psoriasis has linearity. Keep that in mind. When it becomes chronic, it becomes lichenified, meaning the skin is thicker, hyperpigmented, and continuously itching. This is probably a pyogenic granuloma. I'm not sure why it's here. And you can see there's increased skin lines here. Increased skin lines. You can see lichenification and what they call lichenoid inflammation on biopsies. Usually it stops somewhere. This guy has it on the dorsal side. Sometimes it's the nickel in a watch that can do that. This here is maybe some contact that the patient had. Sometimes when it's around the belly button, it's usually due to an allergic contact to a snap in a pants that people are allergic to as far as nickel goes. Sometimes it's due to a cream that patients use, or an aftershave cologne, etc. So you could do nickel allergy patch testing and send them somewhere, but the bottom line is it's probably not worth your time. If they're very concerned and wonder what they're allergic to, send them to an allergist. And remember, always doubt yourself and make sure that you're on the right track. This is a patch test. Different wells are put on different numbers here. About within 48 hours, if there's a reaction, you usually see it there. You then quantify the reaction as severe, moderate, or mild. And then you have to make sure there's an association with the allergen to what they're really doing, because you might be allergic to stuff you never come in contact to. So it's got to make sense. It's got to be real. Same thing. You wore a new shoe. The new shoe has some chemicals that your toes don't like, and what you get is these erythematous, scaly patches, and because you've been scratching it for so long, they're becoming lichenified. Maybe you got a new underwear, and you're allergic to the strap in the underwear, and you get this type of reaction. So there's a lot of different things that this lady got it because she was in contact with a cleaning fluid. She's a janitor at a school and got it splashed with a little cleaning fluid. So the history in this situation is important. You can see acutely they're blistered. There's some linear here. These are usually due to nail polish. When you use nail polish, if it's not totally dry, you have a scratch, you get it by your eye, you get into a contact dermatitis-like situation. This was for a patient who was using anti deodorants in the armpit, and you could see linear, to lipstick. I mean, you name it. I've seen them all, to tattoos, to implants, to this, that, and the other thing. So just and some are more severe. When it's very, very severe, you might have to keep them on prednisone for a little bit longer. So so if you put someone on prednisone for 15 days, you really want to see him back in 10 days, because if he goes off it and you don't see him in 2 weeks and they're not ready to have the prednisone withdrawn, they're going to just have a flare up. And so that's the whole point. And some are really more severe than others. So, roost dermatitis, okay? Most patients come in with a history of having worked in the yard, or usually we see these people in the spring when things start to flower, or in the fall where they're out there raking their leaves. Occasionally, they're on trips or they come in contact with something of that nature. I really don't want to spend the time, but these are the leaves. If they bring it in, hopefully you're not allergic to them. You can see oak has this discerniation of the leaf. Every oak tree you ever look at has it's a 3-petal leaf, but actually, you know what? Actually, oak, I'm going to take it back, does not look like that. Oak trees have a different type of look. So if you want to memorize it, go ahead and do that. But this is what the leaves look like. They're on a stalk with the sumac, and there's like a bunch of leaves that come out. They're symmetrical. They've got these striations on the leaves themselves. Patients don't really bring it in. They just come in with a rash, and we need to. And this is more academic. I'm not going to get into it. I want to teach you guys the clinical, not so much the academic of distinguishing which plant they came into contact with and which ones they didn't. Now, this is something that we commonly see. And as a matter of fact, I actually saw a patient this week with another employee, another provider, that was having a problem controlling the severe atopic dermatitis. We actually put her on it's a steroid-sparing drug which they use as an anti-rejection pill. It's called Celsep. So if you're going to be that aggressive, you really need to know more about it and how to manage it, what parameters to follow, and how to use it. But for now, for intents and purposes, we're going to just talk about people that could be controlled with less effort. Now, one of the things that I see here is tacrolimus and Eladil, okay? They were put on this earth to be steroid-sparing medications, and there are a lot of dermatologists that use them. We choose to try to avoid using them because they have a black label box that states that they've had patients who've used them who developed lymphomas. So, we try to avoid them if we can. Never use PO steroids because you get rebound effects, okay? Phototherapy works very well, but we don't have a phototherapy machine. I used to, but I do not have any. Borrows, and what do you think this is at? ABX is warranted. Antibiotics, okay. Anytime you see yellow discharge, okay, you need to use antibiotics. But I'm going to tell you how to treat these people in a little bit. Most of the patients that have atopic dermatitis will tell you that this began early in their childhood. And some of them will tell you that they have hay fever or asthma. So they could be associated with two other conditions. And a lot of times they're admixed with patients that have keratosis pilaris. After years of scratching, they develop lichen lines and hyperpigmentation, especially along the creases of the antecubital and popliteal fossas. But you could see it spares no place. Anywhere, body, face, you name it. And it's so hard to control. So what I want to do is I want to refer you all back to no wetting. That's very, very important. Do not wet the skin. Very important. Use washcloth in localized areas, etc., etc. And you can see what happens is that it gets progressively worse. When they first have it between birth and 2 years, it involves the face, neck, scalp, and trunk. But as it goes, it involves areas beyond the initial ones. Now, I'm not big into barrier protection, other than not using water. But Dr. Tager put together some barrier repair products, which probably just disallow the wetness of the skin on one hand, and then prevent the dehydration of the skin on the other hand. I find in my practice that it's just easier to tell the patients not to use water other than to specific areas, and they do pretty well. Okay, what I like you to do is always, there's a few categories of ultra high, high, mid, and low potency topical steroids. Get used to using one in each class. So for instance, if you're going to use clobetasol, which is always right for the generic too, because if you write it in the trade name, you're going to get in trouble. The patient's insurance may not cover it. They're going to have to pay more money. So get used to writing things in the generic. So I'm going to click into the notes section here. And just for those who don't know, clobetasol is Temovate. But write the generic, please. Okay. Lidex. I'm not giving you my favorite from each category. Lidex cream is fluocinolone, and I usually use it as a 0.05% medication, cream or ointment. When we get to the mid potency, I like to use triamcinolone, 0.01% cream or ointment. And the low potency, a lot of companies only carry like hydrocortisone. Cortisone, 1%. And for commercial insurances, meaning Blue Cross Blue Shield and the like, I like to use hydrocortisone Valrate. Okay, it only comes as one concentration. It's a little more potent than hydrocortisone by itself. So I think if you just pick one in each category, you'll save yourself a lot of headaches. You don't have to know it all because you're gonna mess it all up. Take my word, I've been there. Just use that. Plus, I remind you, we will not pre-authorize for any of these medications if you write it that way. Okay? Okay. So people have their favorites. So, we're going to skip these and move on to, you could read these notes. You know, it's pretty widespread. Atopic dermatitis begins early in life. There's some association with urticaria and food allergy. I mean, you could always, if you suspect something by history, send it to an immunologist for either for really RAS testing. It's an allergic. It's a blood test that says what some of these patients may be sensitive to. You know, egg, milk, peanuts, whatnot. But it's not the mainstay of the therapy. That's if you happen to see that this is a possible problem. That the mother says every time he eats this or that, it gets worse. Okay, so you're tipped off. Now you're investigating what could it be in the meal that could make it worse. Okay? I do not want to see hydration using lechydrin because lechydrin is irritating. It's only to be used when there's absolutely no itching, when the inflammation is gone. So I am taking this off the list. No, you know what? I'm not going to take it off the list. I'm going to adjust it to say no, no, no. I see people doing that and patients get worse. Okay? Until the redness goes away, the itching goes away. No, 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 lechydrin. Okay? Get rid of the stuff first before you decide you could use that. Aquaphor is good. It's just, but I can tell you, you know what? Vaseline is just as good as Aquaphor. It's just a little more greasy. This is not as greasy, so it doesn't work as well. You know? Exacerbations, you see, I wouldn't even say excessive. I would say any bathing. Low humidity, which we find during the winter, Emotional stress, I've not seen that. I think stress makes everything worse because you become uptight and a little itch becomes a big itch, okay? Xerosis is xerosis. Xerosis has no inflammation. So if you want to think of that, the way I think about it is it's not associated with inflammation, so you can use, has no inflammation, so can use like hydrin. Okay, overheating causes so overheating doesn't really cause that. It causes Crystalina, other conditions. So let's not take about. We're gonna talk about that in another lecture. We've talked about the association of atopic dermatitis, allergic rhinitis, and you know what? You should ask the patients that, just for your own edification. And we're going to see some conditions, some effects of eczema, such as the Denny Morgan folds in a second. The oral pallor. And why is that? Because when we treat the patients, we end up, well, the inflammation, I'm so sorry, the inflammation paralyzes the melanocytes. So if you have severe inflammation and melanocytes are paralyzed, there is no pigment there, and hence it looks paler compared to the other areas. And then, of course, the hair toxin, which is loss of lateral eyebrow hairs. So let us look and see what all this means. Okay, Denny Morgan folds are these folds that you see under the lids. You see that? They're very accentuated. Sometimes, and you could see them right here too. You can see it under here. What it is, it's like canified folds. So the folds appear to be thicker in nature, and that is very nice. Headlight sign is you could see the paler area right here in the central face going up towards the lids. Here you see the loss of lateral eyebrows with the atopic eczematous, lichenified, inflamed meaning erythema, and post-inflammatory hyperpigmentation. Post-inflammatory hyperpigmentation is an indication of previous inflammation. Anytime you see post-inflammatory hyperpigmentation, it's that, unless, of course, you're dealing with other conditions, such as melasma and a few others I don't want to get into, like, we'll get into that later. I don't know what this bleach bath is, but forget about it. It's in here, so I'm leaving it. I'm not sure about it, and I won't put any bath whatsoever, bleach or no bleach. When one gets patches that are oval, such as this, there's a few differentials, and I see a lot of providers misdiagnose it. Okay, they call it tinea. They call it by other names, but basically, if it itches a lot and there's no central clearing and there's no scale on the periphery, you're not talking about tinea. Okay. nodular eczema is sometimes people look at it and they confuse so many conditions that it kind of behooves me. You know, once upon a time I was told that you need to listen to the hoofs of horses, not zebras. And so the first thing you do is you think about the most common conditions, okay? And then you think about other differentials. It has scaling here, you can see. It's oval. It itches. It's all over the body. If you ask patients, sometimes they take 2 or 3 showers a day. There's so many people now that go to gyms in the morning. They'll take a shower. Then they go to the gym in the afternoon, they'll take a shower. And sometimes they take a shower before they go to bed. And then they come in with these rashes and they wonder why. A lot of times we see it on the legs and people start thinking, well, let's see, do I see a little purpura? Is it from itching or are we dealing with a vasculitis? If you're not sure, do a punch biopsy. Okay? Okay, punch biopsies are used for inflammatory conditions. Most lesions, meaning growthy lesions, most lesions can be diagnosed by a shave biopsy, but not inflammatory. So don't make the mistake that you're in a rush, you don't put a suture in, you don't want to do this. Just do the right thing. If you think it's inflammation of some sort, okay, or an infection, do a punch. If you think it's some sort of tumor, then you do a shave. Okay? So most of the time you see these conditions of nodular eczema on the lower extremities and the trunk. I have not seen a lot of them on the upper extremities. Again, and if you're not sure whether you're dealing with lichen planus or tinea of the body, then do a biopsy. Also, there's a condition called fixed drug eruption. We see plaque-like erythematous lesions on extremities. Sometimes, a lot of times, they're symmetrical. You could ask them about a drug history. If you're not sure, do a biopsy just to make sure you're not mistreating somebody. These are other examples. You know, is it lichen planus? Is it discoid lupus? Is it, fixed drug eruptions? There's a whole host of differentials. If you're not sure, biopsy it. Stasis dermatitis. What is stasis? Stasis is the same thing as not moving. When something is stationary, it's static, it doesn't move, and what happens is that the serum from the blood vessels, because the blood is really not moving in a proper speed, leaks out of the spaces between the endothelial cells, and then they go into the dermis, epidermis areas, which, whenever something in the body is in the wrong place, it should be in the vessels, not in the skin. The skin starts to have a sensation of itching with and without some scaling. So eventually you get to a point where you got some scaling. You could even have blisters like here. And when it becomes very chronic, okay, sometimes the blisters break down because the pressure from the serum causes the blood vessels to, under pressure, to become occluded, and therefore they can't serve the skin and you get an ulceration, or which is deep, or an erosion, which is more superficial. So you can have all sorts of variations from that. And sometimes when you have an ulcer, we actually do a biopsy because we want to make sure that it's not an ulcer due to basal cell carcinoma or squamous cell carcinoma or a condition called pyoderma gangrenosum. So you can see variation depending on a time-dependent mechanism. Now, once the fluid is in the skin doesn't grow well, so it starts producing scaling and itching. So you scratch it, okay, and then it becomes hyperpigmented and lichenified. These are all the signs of stasis. You could see. Now, there's one condition which you really have to distinguish this from others. Okay, so we have to distinguish this condition from what they call dermatoliposclerosis, which is a condition whereby the subcutaneous tissue becomes sclerotic, and actually the leg going towards the ankle looks like an hourglass. And we cannot treat it in the same manner that we treat stasis dermatitis. So I would like you to look at some pictures of dermatoliposclerosis for comparison. Sometimes patients get this type of lichenification where you got thickened area, they're almost like keloids, okay? Sometimes it's just lichenified with hyperpigmentation. This is a variation of what this condition can do to a person. The trick in treatment, the most important trick to prevent it from continuing is to use compression stockings. And you can give them a prescription for, and I'll write that down for you, for Job's. This is the way you write on the script. Job's stocking, 20 to 30 millimeter per mercury. Okay, pressure, knee high. Okay, so they put this on when they get out of bed, and they can take it off before they go out of bed. They need to go to a pharmacy that carries the Job stockings or the like. But it's a gradient of compression whereby it's a tightest on the ankle, and as it goes towards the knee, it becomes less and less. Now, once you get an ulcer, there's all sorts of different ways of treating these ulcers. Biofilm is one. Regranex is very expensive. Sometimes people could go to a wound center, but they can mess you up. It depends if the wound center is good. Okay? But the best thing to do is to be proactive and get that boot on ASAP. Okay? Because what you're treating are usually incompetent veins with valves that are not working well. So if you place compression, it pushes the venous circulation back towards the heart. Also, many of these people are very inactive. They sit around most of the day. They're overweight, so they don't move around. Hence, the veins get bad. There's no muscular contraction to push the blood from the veins into the upper part of the body, and hence there's a collection of serum in the skin, and the process begins. If it smells bad, put patients on oral antibiotics because they probably have an infection. I like using Cipro for the most part for anything below the knee, below the thighs or below, simply because it covers both gram-positive and gram-negative bacteria. Lichen simplex chronicus is a condition whereby the skin thickens, is a reactive process to pressure or scratching. You get accentuated skin lines, as you see here, plus hyperpigmentation. You see it in many, many conditions. The idea here is to prevent the itching, the scratching, and sometimes we actually use intralesional steroid injections as well as topical, strong topical corticosteroids. But we do follow the patient. We just don't give them the steroids and say, adios. No, we check them, we see if it works, and if we have to change management, this is what we do. A patient like that, for instance, I would inject them with a stronger than 0.25 milligrams per ml. I probably use twice the dose, if not more. I would ask them to come back in 6 weeks to reevaluate. Most of the time, these go down. Then I'd re-inject that. And you could probably get away with 2 or 3 visits to inject these, along with topical steroids. This again, you can see, is lichenified erythematous. It's still angry. So you need to, the lines are exaggerated. It's probably a cause which is unknown to me, but it's just an example of lichen simplex chronicus. And this is the epidermis. And what you can see here is a thickened stratum corneum. This area between the pink and the purple is known as the stratum granulosum. It's usually thickened. It's called hypergranulosis. And whenever the skin is scratched, this layer of the skin in the middle here becomes a few layers thick, and it produces this scaliness too. There's always inflammation here in the dermis, so when you inject the steroid into it, it kills the inflammation. That's the first sign that the itching is going to go away. Inflammation causes itching. So that's what we do. It could occur anywhere. You could see that. Here's our other cases of this. Now, once you mess around, especially with dark skin, and you kill the melanocytes by scratching, you could get areas of hypopigmentation along with areas of hyperpigmentation. Hyperpigmentation, lichenified Danny Morgan's lines. Okay. Hertog sign. This patient probably has atopic dermatitis. Diaper dermatitis. We were looking for Lasar's paste, and now we found it because it's right here. There are variations of Lasar's paste, okay? This variation has bar solution and hydrous lanolin and Lasar's paste. You can put it with or without salicylic acid, and it's phenomenally effective. There are variations of this compound. You need to send the patient with a prescription for this to a compounding pharmacy, and it needs to be applied every time the diaper is changed. Give them a large jar meaning maybe, 1 pound, and see the patients back every week until they're better. The parents really appreciate that kind of stuff. So diaper dermatitis, you need to continuously change diapers every time there's wetness from the ammonia and the irritation of the urine. That needs to be changed. And then every time there's a change, the Lasar's paste needs to be applied. This is to a point where there's superficial erosions. That's how bad it is. Now, this diaper dermatitis occurs in nursing home patients as well as young people. This is extreme. If this does not get better after a few treatments, and sometimes not even, but there's signs of what looks like seborrheic dermatitis and around on the scalp and or peripheral erythema and scaling of the perioral area. You need to think of histiocytosis X, and or if there's diarrhea, okay, you still need to think of histiocytosis X. It's a form of a lymphoma or of the histiocytes. And or you also have to consider, when it's only in the diaper area, a form of zinc insufficiency. Okay, so if that's the case, you're going to need to do a punch biopsy, okay, to rule out histiocytosis X, and a blood test for serum zinc levels. Otherwise, if you use Lasar's compound, this should go away pretty nicely. And you will become a hero in this little kid's family tree. We're going to skip that, okay? You have to kind of rule out also candidal dermatitis, but most of the time, Lasar will clear that up too, so it should not be a concern, okay? Now, there's a condition called perioral dermatitis of childhood or adults. It doesn't really matter. It occurs in adults, in children. I've mostly seen them in adults. And I'm going to refer to this in adults, so bear with me. What it looks like is mostly perioral, but not necessarily just down here. You could get a lot of skipped areas, and you could see some erythema papules on the upper lip and the cheeks. They could be scattered. There could be many. You could see in this patient, there aren't that many. The only significant history you need to take is have the kids anybody's used new products in their mouth, and if so, did they use it before, or are they still using it? Has there been a change? And since they've done that, has somebody had this eruption? Most of the time I get no, and we never find out the cause. Usually what I do is I treat patients with an oral antibiotic such as minocycline. And kids, I believe you have to wait till they're 12 years of age or older, maybe 10. I'm not sure. I will check that. In adults, it's not a problem. I usually start them on 50 twice a day, then 75 twice a day, then 100 milligrams twice a day. Then for the first week in adults, I give them a very strong topical steroid like clobetasol. I tell them to use it for first 7 days. When I write for steroids, I say first 7 days, then DC, then apply triamcinolone 0.1% ointment, as I do with the clobetasol ointment because it works better. It's more penetrating. Apply that for the next 1 to 2 weeks. I usually see it back in 3 weeks. They're about 80% improved. And then what I do is I kick up the minocycline to 75. I usually release them from the topical steroid creams, and I could just deal with the systemic antibiotics, and they do very, very well. These are just, it can involve in the periocular area. You can see this here, you can see that here. So it doesn't have to be, because it's called perioral. It's kind of a misnomer. It occurs anywhere, okay? This I would treat as perlesh. Perlesh is when the saliva gets out of the mouth and drools on the side. It's a combination of the yeast and inflammation. And what I do with perlesh, I do the same thing. I tell them to mix clobetasol ointment with a little antifungal, say Loprox, for the first week to 10 days, and stop it, and use maybe some triamcinolone. But usually there's an inherited promise to why they're dripping. And so you have to kind of find out what the problem is. I don't know if there's a glossitis here. It looks like there might be either a geographic tug or a true glossitis. The geographic tongue is one which moves by days and weeks from place to place. It's seen mostly in psoriasis, but in a few other conditions too. So this perlesh or angular dermatitis is what we were referring to in the above. I'm saying, when I say in the above, I meant in the above being the last slide you saw. Right here. Right here. This is lichenified because there's a fissure here, and there's hyperpigmentation and a little plaque there. We talked about an eczematid reaction. The id stands for eczematid. Often you'll find dermatologists tend to abbreviate an id reaction, an eczematid, by stating that it is just an id reaction, but it's really known as an eczematid. And what you do in this situation, it could get so crazy where it's a reaction to something else. It's not eczema. It's not eczema. Let me highlight that. It's eczematid. So you drop out the tid. Tid means it's related to some ID. Maybe ID is infection, right? So it's eczematid, and it's usually due to an infection somewhere else. Most commonly being fungus of the feet. When you take off a patient's shoes and you find that they have onychomycosis, meaning subungual hyperkeratosis, where the nails are a little deformed and there's like a lot of hyperkeratosis under the nail plate, more than likely they'll have tinea pedis. So onychomycosis is associated with tinea pedis, and as a result, they tend to develop a reaction by the body that cannot be focused and localized on the feet, so it gets kind of loose and involves other parts of the skin. This hydrotic eczema could be a pure form, or could be a reaction to a fungus on the feet. So I always tell people, if you see someone with this hydrotic eczema, don't get lazy. The first thing you should do is take their shoes off and start examining the feet for onychomycosis and tinea pedis. And if you find out that they have that and you treat that, by golly, you're going to get rid of their condition for life. Because if you don't find that out and they're stuck with that diagnosis of this hydrotic eczema, they will be seeing you for the rest of their life and getting all sorts of prescriptions because you missed that diagnosis as an eczematid, which looks like dyshidrotic eczema, but it's really not. It's just a reaction. And then it could become lichenified, etc., etc. So that's a more chronic stage when you start seeing hyperpigmentation, lichenification, and so on and so forth. Now, there's a condition that you need to know. It's called dermatosis. It's called actually pustular dermatosis of the hands and feet, which resembles, dyshidrotic eczema, but there's usually pustules. Don't confuse that with dyshidrotic eczema because the treatment is totally different. So are you seeing pure vesicles or are you seeing a form of pustular dermatosis of the hands and feet and you just misdiagnose it? So always, remember what Dr. Tager is saying. All eczema that appears, it may not be eczema, it may be one of other conditions. So please doubt yourself. There's nothing wrong with doubting yourself because when you doubt yourself, you usually get things right. So try to get it all right. And that is the end of our lecture for today.
Yeah, I did it.
There I am.